you'll have to bear with the revolving door meeting that we've got today. And if I get anything wrong, Richard May, or miss anything out, please let me know, because it is quite complicated today. So first of all, hello to those that don't know me. My name is Jill Houghton. I'm currently a non-executive director at KGH and NGH, and I think the title may or may not slightly change depending on the approval of paper 2. So a couple of housekeeping rules. If you could manage not to use the chat for comments and questions, that would be very helpful. But obviously, if for admin reasons you need to pop out for a minute, that's again extremely helpful. If you could raise your hand, or if you want to make a comment or a question, that would be better, and then Richard can capture it for the minutes more easily. You will have seen that Richard has started a recording of this meeting, and it will be put on the website afterwards. If anybody has any objections to that, could you please raise them now? No? Good. Okay, so welcome again to everybody. We've got some welcomes in absentia, I think. So we've got Stephen Liney. Stephen, are you here? I don't think so. Stephen is now a public governor for Wellingborough, filling the seat vacated by Sophia Davis. So welcome in his absence. I think I did see Jonathan Smith, did I? Join us?
Yes, you did.
So yeah, welcome to Jonathan, stakeholder governor, appointed by Kettering Mine to replace Andrew Stephen. We've also got a couple of new NEDs, again subject to the paper at item 2. Apologies from Denise Kirkham, who will be hopefully one of those NEDs, and Caroline Stevens, who I can see on the screen. So special welcome to all those individuals. In terms of declarations of interest, all non-executive directors will have declared their interest in item 2, and at that point I will pass the chair over to Simon, and we will be asked to turn our cameras and our microphones off so that the Council of Governors can have a discussion without us. Simon, I don't know how long you'll want for that item and how you want to bring us back. Do we set a time, or do you want to text me?
Gosh, I better text you if I've got a contact for you.
Okay. Hopefully you have. Shall I put it in the chat while we're away?
I can do that, Jill, if that's helpful.
Put it in the chat. Are either of the Richards staying with us for this?
Both, yes.
Richard May is. Okay, yeah. Well, Richard will be able to do that. I will not need too long. I'm going to just run through basically the documentation that came with the agenda and our decision, and there's just a couple of additional points to make. So
okay.
And I think some of the governors, if not all of the governors that will be in this discussion, were probably at our earlier meeting in the week anyway, to know the background to this.
Actually, just to make life easier, if Richard May, would you mind texting Alice, who's excellent at contacting us all on Teams? Because I'm just thinking I need to contact everybody.
No pressure then, Alice.
Put the pressure on now there, Jill. Yes.
So Alice can let us know when we can come back into the meeting. Is that okay?
Or Jill, maybe a comment could be put in the chat, because if you put it in the chat,
that's how I'll do it.
We should be able to see the chat.
Oh wow!
Even if we can't, even if we're not on camera or a microphone, we should be able to see the chat. So
fabulous.
That's the way I. Yeah.
Super. So we don't need anything except to keep an eye on the chat. Thank you for your help, colleagues. Okay, we're next on to apologies. I've already given Denise Kirkham's apologies. We also have Andrew Moore, Trevor Shipman, which is why I'm chairing today, Natalie Armstrong, Sue Watts, Wendy Saville, Rashmi Shah, Wendy Patel. Is there anybody else, Richard May?
Not that I'm aware of, Jill, no, thank you.
So we will have Damien joining us at some point, and he will be providing us with an update on the Finance and Investment Committee just after Richard Mitchell's feedback. or update. We will have Chris Welsh, who's been delayed for unavoidable reasons, so he will join us at some point. And as Alice has already advised, we'll take Alice first in terms of the updates, as Alice has to be elsewhere, which is why I said it's a bit of a revolving door meeting, but we'll get there in the end. Okay, so I think I've covered everything. Is that okay, Richard? Everything sorted for the first section? Yes?
Absolutely, yep, thank you.
Fabulous. So now we're on section 2. So non-executive directors, we will now switch off our cameras and our microphones and keep an eye on the chat. Thank you, everybody.
Okay, Simon.
Okay, we're clear. Right. Well, morning, everybody. All of you that are left. This is a brief summary of what was decided earlier this week, or a process earlier this week, from the appointment and remuneration group. We were asked to approve changes to the KGH board composition, which effectively, in terms of its non-executive directors, but it's complex because of the structure of the two hospitals within UHN. But effectively, those non-exec directors that we recruit and approve will be a team that looks at both hospitals, so UHN. The process went basically, we received 9 expressions of interest, and we interviewed over 3 days between the 24th and 29th of July, and the panel was myself as ARG chair, the trust chair, Andrew, were leading it, Northamptonshire Integrated Care Board chair, an NHS England representative, and an inclusive recruitment champion. So it was quite a panel. Following those interviews, we chose 7 preferred candidates, excuse me, based on their relevant experience, both clinical, but also recognising what they could bring from outside the NHS, which we see as useful. And I think most people would agree with that. And specifically, and this is a question that's been raised a few times around this, we look for drive and determination to challenge and to hold executives to account whilst moving at pace to improve and develop our hospitals and deliver the best patient care. We would say that, of course, wouldn't we? But and what I would say to that is that the panel noted, against the general question about candidates' regrets, if you like, what did they regret most in their careers, they all, to a person, expressed the regret that they had not, those that were involved at the time, that they didn't challenge harder and earlier on in the relationship between our previous chief exec and our previous chair. That's actually, it's quite interesting. And my reading of it was that that was genuine and heartfelt, that they really kind of knew that they should have said something. So the preferred candidates are Alice Cooper, Jill Houghton, Denise Kirkham, Trevor Shipman, Caroline Stevens, Damien Ventukasamy and Chris Welsh. Remuneration is raised slightly from where it was, and there are also additional payments to recognise, well, in respect to the combined UHN team, because they will have responsibilities that concern Northampton as well as Kettering. So we agreed as an ARG that we would recommend those 7 people to the council today. And before we return back, or I guess we should have a vote here now before we return, but comments made during the process earlier in the week of the meeting. One was there is a perceived lack of diversity in the group, but we were recruiting from a small group that was already there. I'm not sure that makes it an excuse, but given the background of significant work on diversity currently going on, particularly at Kettering, it was, I think, a point worth making. And it also as a group, as a committee, we recommend we welcomed, beg your pardon, we welcomed the financial saving, which is around £138,000 a year, by reducing the overall number of non-exec directors. So even with the uplift for additional responsibilities, there's an ongoing saving of £138,000 a year. So that was the recommendation, and I think I'll be right, Richard. We're asked today to approve that as a council of governors. So I'm happy to answer any questions. Happy also to discuss it in more detail outside that, because I think there are probably, I think there's some work to do in our ongoing relationship with non-executive directors as a board of governors, but that's probably not for discussion right this minute. But if there are any questions, I'm happy to answer them. I can't see any hands up. Is anyone unhappy then that we recommend this and move forward and go back to the meeting and say, yes, it's agreed? Deafening silence. Okay. So we approve it. Thank you.
Just Simon, just a note before we ask people back in.
Yeah,
You mentioned
certainly.
the non-execs. A couple of points which aren't in the written papers, which came through Tuesday's discussion in terms of the remuneration for the audit committee. Alice, who will be chairing 2 audit committees, the total remuneration will be 22,000, not 20,000, as stated in the report. And also in terms of term dates, you'll see that there's 2 expiry dates given for Jill. That's an error in the report. The relevant date is the second one, which is for Kettering is the 8th of December 2026. So approving with those 2 caveats, additions, please. Thank you.
Okay. Okay, so we take back then, I can tell the whole group that we approve the preferred candidates.
Thank you very much, Simon and colleagues.
You're welcome.
And thank you for approving the paper, and congratulations to all concerned. We look forward to working with you. I know we all do that, so I'm saying that with one voice. Okay, so we're now on to the minutes from previous meetings. So I'm not going to go through them page by page, but I'll take them individually. So we've got the meeting that was held on the 6th of June. Are there any matters of factual accuracy that anybody wants to raise? And I can't see everybody because there's 2 pages of us now. So let me know if somebody has anything to raise. Okay. Silence is assent that they are approved. And then the set of minutes for the 30th of July. Are there any matters of factual accuracy for this set of minutes, please? No, that's great. Any matters arising other than the one item on the action log? No. And the item on the action log is closed because Sarah Noonan will be joining us shortly. So that's fabulous. So have we got Sarah with us?
Not yet, Jill, but she
but
will
we have
be.
got
She
Richard.
knows. Yes, we do. Yes.
Fabulous. Okie doke. So the next agenda item is Richard. Welcome, Richard. And the Council of Governors are asking if you'll update colleagues, particularly on the restructuring. And there's an additional question, if you don't mind, which is about tackling diversity at all levels across the 2 hospitals. Do you have any update on that, please?
Of course. Right. Good morning, everyone. Lovely to see you. Thanks for the opportunity to catch up. So I'll touch on leadership and then tackling diversity across, or I'd suggest it's improving diversity at all levels across UHN. But as always, very happy to answer any questions. In terms of Leadership. I feel in terms of the most senior leaders across the organisation, and by that I mean the executive team, I think we're moving to a more stable position now. So all of the executive posts have been recruited to substantively, other than the chief nurse. We've got Julie Hogg, who's the substantive chief nurse at UHL, currently acting as an interim chief nurse for UHN. I think in a short period of time, despite the restrictions on her time, I think Julie has made a significant difference at UHN, and she's working really effectively with Hemant, the substantive medical director. We did interview 2 weeks ago, or maybe last week, for a substantive chief nurse. We had 2 applicants, but given the criticality of the job, we didn't think either of them were of sufficient quality, and therefore there were 2 external candidates. Therefore, we're having another conversation next week with the regional team about what is the substantive plan for that. All other jobs, though, have been recruited to, though, combination of the majority of people were already in the roles within the organisation, been acting up, a couple of people for up to a couple of years, and they've been appointed substantively. And Laura Churchward, who's joining on the 1st of October as the substantive chief exec for UHN. She'll be running the organisation on a day-to-day basis. The executive team will be reporting into her. She's joining, probably heard me say before, she's coming from the University College London Hospital, has been their director of strategy there for 7 years. She lives just outside Northampton. Her children were born in Northampton Hospital. Like you and like me, she cares passionately about Northampton and Kettering, and I think she will be great for us. I'm really looking forward to her joining. I'm confident, although I've never worked with her previously, I know a lot of people that have worked with her. I'm confident that Laura and I will work effectively together as a duo, and I'm confident that she will work effectively with the executive team. It has been personally quite difficult over the last sort of 10 months or so, feeling fairly stretched. I think Laura will offer us a lot. That doesn't diminish my interest in being part of the UHN team. And as I said previously, I will continue to be the accountable officer, which I think is an important point. We heard earlier in the section where the non-execs dropped out about the changes around non-exec appointments and about the financial savings. I estimate that the financial savings we have made from a reduction in the executive team is probably in the region of about £1,080,000. So it is not an insignificant amount of money. As I said last time we met up, I do recognise for a whole range of reasons that this process has been difficult for people. I'm grateful for colleagues' professionalism throughout. There are a number of colleagues who have been in UHN for a couple of years and have now left, and the vast majority of them have been able to secure substantive employment, which is good for their ongoing career. The main reason for simplifying the executive structure was not to save money, but I think that was an important byproduct, and we will be saving in the region of. I think the role of a high-performing exec team, and that is where we want to get to, but it's not where at the moment. I think we probably have 5 things to do. I think there is about a point around taking decisions, and I think having a unified exec across Kettering and Northampton enables us, working with our clinical colleagues, to take decisions. I think there's a key point around looking after people, whether they are our patients, but the colleagues within the organisations. And I'll come back to that when I touch on diversity in a moment. I think there's a point around providing a compelling vision for people, whether they are our communities, the people who use our services, the people who work in our organisation. That will emerge more strongly over the coming months, but clearly there is a very key role for service provision at Kettering General Hospital, service provision at Northampton General Hospital, and the relationship between the two. I think as a collective, we have a key responsibility to be contactable and to be approachable I recognise inevitably there'll be a view that we should be more visible than we are. That's work in progress. It's not a lack of interest, it's just time commitments at the moment. But I do think we are all contactable, and I certainly would hope the way in which we communicate, whether that is face-to-face contact or the written word or the virtual sessions we do, I think that has improved and will improve further. And then it's about giving people hope and optimism, recognition that I think there is some evidence that today is better than yesterday, but where we're really focusing on is tomorrow and the long-term strategic vision for the organisation. I think that all of that generates followership. We've obviously got the staff survey that kicks off in a couple of weeks' time. So I think we have to be realistic about for Kettering, given some of the challenges that the organisation has had, some of the concerns that have been raised repeatedly for numerous years now through the staff survey perspective. We have to be realistic about what we can expect from the staff survey this year. Last year we did have an upturn in response rates, which is good. I would hope us to build on that. I would be surprised if we saw a huge change in some of the answers people were giving. I think we should realistically expect in 12 months' time to begin to see that surge in change in people's belief about the organisation. We had a really useful board workshop yesterday, chaired by Andrew Moore for the first time. It was where the execs and the non-execs came together for the first time. I think it felt different. I think it was a really good start. Visibly, there's fewer people in the room. Again, I think that supports all of the points that I've just made around ease of decision making. Whilst I'm trying to make the point that I think we've got greater stability now at a board and exec level, I recognise that there's still inevitably going to be lots of change that the wider organisation will face. And I touched on this the last time that we met up. There are ongoing conversations about how do we bring our clinical functions and clinical divisions more closely aligned with each other. So there is a lack of clarity at the moment. The execs and I are fully aware of that. We want to move to a position where everyone knows exactly what the future means for them, and all of that change will be complete by the 1st of April. Hopefully before then. Obviously, we are trying to make a huge amount of change during the time of year, which often is the most difficult time of year, and Sarah will touch on that. I think in some respects, UHN and Kettering and Northampton is in a better place than it was 12 months ago, and in some respects, I think it's in a worse place. But I think we've got a better understanding now of the risks that we face. I do feel that some of the conversations we're having are more open and honest, and I think we're beginning to get to grips with understanding how we're going to resolve some of these long-term challenges. In terms of then moving on to improving diversity at all levels across the organisation, I would hope you would have read and heard from my communication from week one, which was the beginning of November 23, that inclusion and diversity and equality really is of significant importance to me. I'm aware, as you will be, that if you look at the executive team, we are not the most diverse group, neither are the non-executives. There'll be a whole range of reasons for that. I think two legitimate points are, well, I think probably the most legitimate point is the vast majority of the executive and non-executives were already working in the organisation, so we didn't really have an opportunity to begin to change the team. I do think across the execs and the non-execs we've got really good people, though. When you step down into the layer beneath us and you look at clinical directors, senior nurses and others, there is greater diversity. However, the leadership of the organisation doesn't replicate the wider workforce of the organisation. And as we discussed in detail in our board workshop yesterday, when you look at the staff survey and you look at factors such as bullying and harassment, violence and aggression, exclusion, certain demographics of colleagues disproportionately feel that. And sometimes those demographics will be colleagues from ethnic minority groups or from the global majority and colleagues in less well-paid jobs. So I would hope that some of the communication around equality, diversity, and inclusion has begun to improve through the work that Paula has been leading on. Paula Kirkpatrick, our Chief People Officer. Hopefully you would have seen in terms of our staff survey response to 23, some of the particular aspects that we've begun to put in place to improve the culture of the organisation for everyone. And then yesterday in the board workshop, we had Roger Klein, who's a national lead on this, coming in to begin to challenge some of our thinking and some of our ways of working. We're nowhere near where we need to be from this aspect, but I do believe some of the work has begun, and I think we will begin to see some of the benefits of that within the next 2 years. Very happy to answer any questions around leadership, diversity, or anything else.
Thank you, Richard. You briefly froze when you mentioned the amount of savings that were being made in relation to the restructuring. And I know it's only a side product, but people would probably be interested to know how much it was.
Of course, yes. Thank you. Poor timing from the IT investor today. I estimate it to be £1.1 million recurrently that we have removed from our cost base. That are, just to give, I won't go into the specific numbers because there's obviously sensitivity, but we've gone from, we've obviously reduced the number of chief execs in the organisation. We've reduced the chief nurses, the medical directors, the chief operating officers. We've got half of a CDIO going forwards and a couple of other points. So don't know if you caught this point. I think you were alluding to it, Jill. The primary reason for simplifying and reducing the volume of execs was not to save money. It was to make decision making better and to just to improve the organisation, etc. But I do think, given our financial constraints, it's an important byproduct. And £1 million is a material number.
Thank you very much. So, colleagues, any questions, anybody of Richard? Kath?
Thank you. Thanks for that, Richard. When you talk about taking decisions and making the decision better, are you talking about the quality of the decisions or the speed of the decisions? Because one of the things that we experience, because I'm a staff governor, is how slow and how protracted some of the decision making can actually be.
Good to see you, Kath. It's got to be both, hasn't it? Because we could, let's all agree to do something now, but we haven't really thought it through, and it's a terrible decision. So that's not going to benefit the organisation. We need to take good quality. I think there's three aspects. We need to take good quality decisions. We need to do it in a timely way, and we need to do it in a way that is inclusive of the subject matter experts. I've worked in NHS organisations where decisions have been made on my behalf. I then have to enact them, and I find it very difficult because I don't support the decision. We are nowhere where we need to be, and I'm aware that there's 11,000 people across UHN. And a lot of what I've just been through at the moment probably won't resonate with them because it hasn't percolated through the organisation. But I do believe, and there's lots of evidence to support it, when the decisions get to the executive team and when they get to the integrated leadership team, which is where 90% of the decisions take place and have our clinical leaders in there, we're transacting the vast amount within a week.
Thank you.
Just the final point I'll just add to that is what I don't want us to be doing, because I think the organisation has been, is over-reliant on the execs and then the next tier down to take decisions. I think our job is to set the framework and to empower the local leaders to take the decisions to the best of their ability.
Yeah, I agree. Thank you.
That's very helpful. Thank you, Richard. Keith?
I'd like to congratulate Richard for starting the right way. As we know, we've got to close the structure down in the administration with the health services so it can survive. But I can see you've actually going the right way. Congratulations on that.
Thank you, Keith. Good to see you too.
Thank you. Jonathan?
My apologies for what is going to be a very simple question to everybody else, but this is more just coming to you, Governor. Rich, would you mind telling me what your role is within the organisation? I gather it's some form of HR role, but beyond that, it wasn't very clear to me what your actual role is, and it helps me understand what's going on. And just as a more general request, when people sort of are introducing themselves, would it be helpful if people could just say what they do just for my sake? Because there's going to be a lot of new things I'm going to have to learn. So sorry for a very basic question.
No. Apologies, and thank you for raising it, because you won't be the only person thinking that. So it's good to meet you, Jonathan. I don't think we've met before. So I'm Richard Mitchell, and my substantive job is I'm the Chief Executive of the University Hospitals of Leicester, and I'm also the Chief Executive of the University Hospitals of Northamptonshire, of which Northampton General Hospital and Kettering General Hospital are the two main sites. I've been the Chief Executive of UHL for 3 years almost to the day, and I've been the Chief Exec in UHN for I think 10 months, maybe. Yeah, 10 months. The point I was making earlier was the thing around being the accountable officer. So Chief Execs, we're accountable for the organisation. If things go wrong, it sits on our shoulders. My job is to work with the execs to hopefully deliver high quality of care to all, to be a good employer, to manage the money effectively, to work with general practice, local authority, and a range of other things. Given the size of UHN and UHL combined, which is 2.5 billion and 30,000 people in 3 separate statutory organisations, there's no I'll use the word group. There's no group in the NHS that is working at the scale that we're working at with the complexity that we face at the moment. So possibly my intention 10 months ago was to be the day-to-day chief exec of all 3 organisations. I think it's evident that I'm not doing that as well as I would like to, simply from a time perspective, and that is why we have Laura coming into UHN on the 1st of October to run the organisation on a day-to-day basis. She will be the direct point of contact for the vast majority from a chief exec perspective. My job then steps into continuing to run UHL on a day-to-day basis and to strengthen the strategic alliance between UHL and UHN. Does that make sense?
It does, yeah. Great. Thank you very much. It's helped clarify a bit for me.
Of course. Thank you.
Thank you, Jonathan. So apologies, I should have asked colleagues to introduce themselves before they spoke. There's probably too many of us to go around the room, so to speak, but a very helpful question. So colleagues, when you do put your hand up, if you could say who you are and what your role is for the first time you speak, that would help enormously. So thank you. Any more questions for Richard or comments? No?
May I just say one further thing, Jill, and it was a point that we touched on the table that you and I were at yesterday, and I'll use the phrase that I used yesterday, which is, I think it's easier said than done, but I want us to hold our nerve with what we're doing, because I don't believe I have today, but I could try and paint to you a really positive picture of everything's going really well. That's not the reality. I could say to you, we're well on the way now to recovery. That's not the reality. But I do think, against some respects, in terms of governance, leadership, a range of other important factors, we've got more foundation stones in place now than we had 10 months ago. So it's going to be, as Sarah will say, it's going to be a really difficult winter. We've got incredibly challenging agenda with finance and with safe care and other factors. I'm not sat here saying it's great. I'm not sat here complacent. But I'm saying let's hold our nerve, and I'm confident with the people we have in UHN and with the changes that we've made. I think the experience of working in the organisation, the experience of receiving care in the organisation, the experience of being part of the wider UHN community, I think will change. It's not going to change in the next 6 months. But I do believe, realistically, come September 25 and certainly September 26, it will be materially in a different place.
Thank you. Damien has arrived ready for his update, but David, I think we've got time for a quick question from you.
Yeah, hello. I'm David Harlan. I'm Public Governor for Corby. Yes, much of what you said, Richard, very much resonates with comments that I've received from staff when I've gone in, walked around various parts of the hospital. But one of the things that's sort of struck me since I've been a governor at KGH is the quantity, the volume of activity the rate of change, some of which the trusts are not in control of because it's forced upon you from outside external circumstance. How is the trust going to manage that? Because I think it's quite critical, because I do sense at times that some of the issues are a result of overload. There's just too much coming through, being pushed all the time. And as I say, I do appreciate that some of this is external and you don't have any control over it. But I have sensed that that is part of the issue. I just wondered whether you share that view, and if you do, how the organisation is going to tackle it.
Yeah, good to see you as well, David. No, I share the view, and I think one of the concepts that we're struggling with at the moment is the need to run the organisation and the need to change the organisation. And they are similar and they're different. And if we don't change the organisation, the operational pressures that we face today will be worse in 2 or 3 years' time. So we have to carve out a way of making today better, but then beginning to embed the change that makes next year better. I recognise, having been head of operations, a divisional general manager, I'm non-clinical, but I've done a whole series of managerial and administrative jobs in NHS organisations. I recognise that the people in those jobs, the middle tiers and the lower tiers, in many respects, their jobs are way more complicated than mine, because they just have loads of high volume requests coming their way, and they're not really in control of them. So what we are trying to do, but I'm aware there won't be a huge amount of evidence at the moment, is I think a single exec working effectively begins to send out clear messages into the organisation, and we can begin to ask people to do things once and explain why we're doing those things. And people who need to transact these changes will be in the rooms for those conversations. I would hope, and we touched on it yesterday, that one of the things that I can do and other execs are doing is trying to absorb, given we're amongst friends, a lot of the nonsense that comes down from external partners. You can envisage that I get a lot of requests, and quite a high number of them I just don't do anything with because I don't think they're going to add value to the organisation. So we want to sift as many of those out and make people's working lives easier. I think the final two things I would say, I listed the points that I think we are trying to change as an exec. I hadn't thought of this, but I will now add it to my growing list. I think part of it is about simplifying people's working lives, which probably is at one of the roots of the point that you're making. We do need to make it easier for people to do the right thing. The final thing I would add to that is, I believe a greater proportion of the organisation now feel able to speak up about their concerns, whether they're big macro things or just relatively small points of annoyance, than 12 months ago. And I want to continue to urge people, if they're not happy with something, or they don't understand it, or there's a better way of doing it, try and find a local resolution to that. But if you can't, you've got Richard Apps, you've got me, you've got Sarah, you've got a range of other people, make contact with an exec, because I'm now confident that we will respond to your concerns in a timely and appropriate way. So I absolutely agree with the point that you've made, David. It's very much work in progress.
Thank you, colleagues. Well, we've got, as I said, we've got Damien waiting in the wings. Sarah, apologies. Before you arrived, I said we're a bit of a revolving door meeting. Damien can only be with us for a very short period of time, so he's going to do his finance and investment update with Graham, and then we'll come back to you if that's okay. So over to you, Damien, please.
Hi, thanks, Jill. Firstly, can I just check, can you all hear me okay?
Yes, thank you.
Perfect. Yeah, I'll keep it relatively brief. And I think in many respects, Richard has given you the headlines that the financial position is very challenged, right, from a UHN point of view. And just in big handfuls, initially the desire was for us to have a break-even position. Through numerous conversations and negotiations, that ended up being an agreement to a 55 million deficit. At month 4, we're off plan. And if we took a straight line view on the level of deviation based on the first 4 months of this fiscal year, we would be somewhere around 100 million plus a deficit position by the end of the fiscal year, which would be March 2020, end of March 2025, which is clearly not an acceptable position. So we are working very hard. We've put a weekly meeting in place to try and determine the best position that we can get to. I was at an ICB meeting on Tuesday, and the desire from them is still very much that we hit the agreed 55 million position. How doable that is, I think, remains to be seen. There are still big gaps in solid concrete actions that will help us to achieve certain aspects of our plan. For example, around cost efficiencies, we still have big chunks of what we had assumed as cost efficiencies that are not at this point in time underpinned by a robust plan to achieve that level of savings. So there's a lot more work that we need to do. I think to Richard's point around governance, I would say I think we've got much better governance around all of this. I think we've got a laser beam focus on the finances that I haven't seen in previous years. So, you know, as I say, it remains to be seen as to how close we can get to the 55 million deficit that's currently within the plan. But the work is going on at a pace to determine that. And I think once we've determined that, we'll be in a much stronger position to manage the finances in accordance to whatever that number may end up being. A little bit of an abstract description of where we are. I don't think it's worth going through the minutiae of the numbers on this call, but it's very challenged. And obviously, and I think as was just said in the previous part of the conversation, there are other pressures which kind of pull us in a different direction. You know, the winter season is soon to be upon us, and that will put pressure on us from a point of view of providing healthcare. So all these things are in contention with one another, and that's partly what we've got to kind of puzzle out over the next weeks and months to come. I'll probably stop there. I don't know if anyone, Richard, you want to add anything to that?
I thought it was spot on. Thanks, Damien. The only brief thing I would add to it is in my head at least, and the way I'm going to sort of try and continue to explain it to the organisation, certainly with partners across the Northamptonshire Integrated Care Board and then with NHS England, is I think our financial improvement has to have two intertwined elements. So the first bit is we need to do everything possible to safely reduce the unit price of the cost that we care, the cost of care we provide. So what I mean by that is, at the moment, if we track a patient who comes into the emergency department and we admit them, we may be spending £1,500, say, on their care. And there'll be a whole range of reasons. Part of that because of the substantive workforce, but it might be that we're too reliant on bank and agency, maybe their length of stay is too long, we prescribe the wrong medication, etc., etc. So what can we do working with our clinical leads to move from £1,500 to £1,200? And that's applicable to emergency care, to diagnostics, to cancer, to planned care, every form of care we provide. So either let's maintain our cost base where it is and provide more care through our planned care pathways, through our cancer care pathways, where we get paid more for those patients. That becomes greater efficiency and provides a financial contribution. Or let's reduce our cost base, certainly through UEC, where we don't get paid for the patients that we see, and therefore the unit price reduces. I think an awful lot of that is within our control, and that's classically where some of the points that Damien was mentioning around cost improvement and workforce and other factors play in. The other point where we really need system partners support and really urging them to engage with this is around the volume of patients we're being asked to care for. So UHL is slightly further evolved from its understanding than UHN at the moment, but I think we have now provided sufficient evidence to convince all partners that the reason why the urgent emergency care pathway in UHL is so expensive is not because it's deeply efficient, but it's because the rate of activity has grown dramatically, probably about 28% over the last 2 years, and the cost base has not increased at the same rate. So we need to get the same level of understanding in UHN. We need to be managing our unit price of production or care more effectively than we have done previously. That's within our control. However, we need general practice and local authority and LPT, Northamptonshire Healthcare and ISB and others to work with us to firmly focus on, and Sarah will touch on it, this winter, the people who turn up in Kettering and Northampton A&E department should only be the people who require accident and emergency care. People who can access care in general practice or urgent treatment centres or pharmacists or NHS 11 or wherever it may be, the nicest possible way, again, given we're amongst friends, we don't want you or need you in our emergency departments. And that requires collective effort. We have to do both of those things effectively, not only to resolve our financial plan for this year, but to begin to open up a much better longer term financial position.
Thank you very much. Just before I bring you in, Keith, Jonathan and others, you'll have gathered that Damien is one of the UHN non-executive directors and has been a convener of the Finance and Investment Committee in partnership with a colleague at NGH for some time, so is well experienced in this area. And also, Graham, did you want to add anything, because you're the governor that is in attendance at this meeting?
Hi. No, I think it covered it. Certainly the bedding in the new organisations, but just I agree with the comment about focus on the finances. It was definitely something that was challenged and looked at. So I mean, our role is to see how the NEDs are not to change the policy, but to see how the NEDs are going. So yeah, there was a full discussion.
Thank you. Keith, before
another day.
Keith, before we move on to Sarah.
Morning. May I ask a question? How does the government fund the National Health Service for all the migrants, illegals coming into the country that actually get free healthcare, prescriptions, etc., etc.? Surely that's a burden on us if we're not actually financed a bit better from the government.
Who wants to take that, Damien or Richard?
I'm not qualified to answer that question. I will defer to Richard on that, I think. Sorry if I'm passing the buck.
No, my hand went up. So I think it's a very sensitive point, Keith. And let me try and find a way of answering it. The UHN receives circa £1 billion a year. And I think the vast majority amount of that money is spent on people who qualify for NHS care, which is free at the point of access. I'd imagine it's probably north of 99.9%. So we're talking about an incredibly small proportion of people. People who do not qualify for free NHS care, we have a mechanism for accessing funding for it. As I say, I imagine it's both value and volume wise a very small proportion of our cost base in UHN. The vast majority of that cost would be funded, and inevitably there'll be some people who require accident emergency care where we don't receive any funding. But if that was our sole problem, I'd be a very happy person. The magnitude of our finances is far greater than that. Has that answered your question?
Yeah, that's it. Thank you.
I would just like to add one thing to that, which is one of the many things I love about this country is the fact that if you need medical help, it doesn't matter who you are, you can get it from the NHS. And as somebody that spent a lot of time in the States, I can tell you that ain't the case over there. So I'm really happy about the fact that we have free healthcare at the point of need in this country.
Yeah, thank you very much. Much agreed. A few thumbs up there. David, before we move on to Sarah.
Hi. With regards to the finances, Damien. One of the things that struck me was that over the last few months, the hospital occupancy has been way, way, way higher in these months than I've seen it before, which I think is probably adding to some of the issues. The other question, though, is do you feel that the hospital is in a position and carries out sufficiently detailed analysis on what's actually going on to actually pinpoint the hot and cold spots so that it can actually target the appropriate points? To give you an example, speaking to one of the surgeons, particular procedures, they've got something, hospital stay time, something like 4 times the expected. And my understanding is that proposals were put forward, but the money wasn't there because of the current circumstances. That was a long term. It would have paid off over 18, 24 months and significantly, but you just couldn't get it past anyone. But there were a couple of issues that I raised with Jill and Chris with regards to patients and their appointments and so forth. And the thing that kind of struck me was not only was it uncomfortable for the patients and the process they went through, but there was actually potentially significant loss and cost to the organisation through those inefficiencies. And I'm just curious as to whether you're comfortable and confident that the organisation is actually able to dig into the detail of it to actually really understand at that level, because my experience basically says that you can look at it from a high level, but unless you actually get to grips with the micro, operationally, you're not going to be successful.
Yeah.
Over to you.
Yeah. Richard's got his hand up. I've got some comments I would make back to that, but if you want to go first, Richard, I'm very happy for you to.
What would you do you want me, shall I start and then?
However you want to do it. I'm relaxed.
Okay, so just very briefly, another good question, David. I think you're saying, are we confident, etc. I'm not. That we are. I think the fact, as Damien was explaining, we have submitted a deficit plan, like wider NHS, but we submitted a deficit plan. We're now unlikely to deliver that deficit plan. Like the wider NHS suggests that we've got some deep challenges. The NHS is an inefficient organisation, and UHN is an inefficient organisation. I was in a meeting on Tuesday, National Chief Exec gathering, and the Secretary of State for Health and Social Care was there, and the Chief Exec of the NHS was there, and other people. And from what they spoke about, some of the reasons for the inefficiency at a macro level in the NHS is because of, I'm apolitical in my role, but they were mentioning a decade of austerity, maybe longer, Health and Social Care Act in 2012 and the impact of that, and obviously the pandemic. We've got massive problems that are beyond our ability to control. What I do think, though, is if you look just through the lens of UHN, is it's an organisation that's running really hot. Kettering and Northampton haven't worked effectively together for a long time. We haven't been able to invest in the stuff that we need to make the organisation work more effectively, which is proper IT that works, digital capability, analytics, estate that's fit for purpose, etc. So we've got a mountain to climb. But I do think, looping back to my opening remarks, that we've begun to really understand and have more open, honest conversations about the challenges that we face. And I know Sarah's going to update on winter in a moment, but I think with people like Sarah and Julie and Hemant and others, we've got a really decent chance of beginning to change the curve. The final point for me, and then I'll hand back over to Damien, I think the real route into this is the point that I made previously, which is we need to get our clinical colleagues and our local managers and leaders into a position where they feel that they can activate the change that they want to make. Damien and Sarah and I, we can't sort out Theatre 12 in Kettering because we just haven't got the time. But the team who are running Theatre 12 in Kettering need to feel empowered to deliver the change they have wanted to deliver probably for the best part of the decades. That's not going to happen overnight, but I think it's perfectly possible to envisage that we will get there. Damien.
Yeah, no, I think you've answered it well. I would just add a couple of things in terms of, like, do we know the areas to look at? From a finance point of view, at a macro level, one of the big overspend areas is staff cost, agency, bank, and overall volumes, right? So we know that. We know that at a macro level. I think what we need to do more work on, but and when I reference the laser beam focus in my introductory comments, is, are we spending that money on the right things in the most efficient ways? Are we overstaffed in some areas, understaffed in others, and all of that? That's the work we need to do. And we're starting to look at really interesting data, like Richard mentioned. What's the cost per unit of a healthcare provision for, say, our urgent emergency care department? And what we're seeing is actually that cost has gone up and up in UHN over the years, and it's probably higher than comparable acute. So we're starting to be able to hone in on the areas, and we're getting more, I would say, data orientated in terms of how we look at these things than we have been historically. But to Richard's point, we're not there yet, and there's a long way to go. I liked a phrase that Richard used in one of our other meetings, and don't misinterpret the word crisis, but he kind of said, let's not waste a crisis. And I think the precarious position of the finances in UHN gives us an opportunity to really focus on how we transform the organisation for the longer term and make it financially sustainable. So I'm not saying we're in crisis, by the way, just to put that caveat, but I like the phrase, which is we have got a financial crisis to a degree. And we can use that, I think, to do the kind of analysis that you're talking about in the question you asked, which I thought was a really good question.
So before I come to you, Richard, thank you, Damien and Richard Mitchell. We're
Richard
running
Apps
quite.
has got a hand up, by the way, John.
I know. Before I come to Richard Apps, it gets terribly confusing, doesn't it? We're running quite late. Sarah, are you able to stay with us for a bit? Because Alice has messaged to say that she had hoped to have already left by now, and she's got an update to give us on the audit committee.
Yeah,
so,
I need to go by 11:30, so I'm all right until then.
Oh, super. Thank you very much, Sarah, for bearing with us. So, Richard Apps?
You have said it, Jill. Thank you very much.
Oh, good. Thank you. So, Alice, over to you.
Thank you so much. And thank you, Sarah. Apologies for keeping you waiting. I'll be as brief as I can. Audit committee first, you'll see the paper in the packs in the board summary section. But I think the most sort of key update is the one I sent via email to the governors earlier in the week on the financial accounts audit piece. That is the piece I would wish to make sure everyone is up to date with, but I'm presuming that you've all read that. Happy to take any questions on that. On other matters on the audit committee, all I'd say is all otherwise we are proceeding to plan. We had our first joint audit committee in common this week, which I think was successful in terms of the process. We've now got some work to do to bring reporting together and make that consistent and combined, but that is all eminently doable, I think, working with the team to do that. The internal audit work is broadly proceeding to plan. We're a little bit behind in terms of the timing of the audits, but only as is typical often at this time in the year, so I'm not too concerned about that. We have some work to do also on financial controls and making sure they are absolutely as robust as they need to be, particularly given the financial challenges that Damien and Richard have just talked about as well, to ensure that we are doing our bit to make sure we are minimising any lack of financial governance we have in any pockets around the organisation. That's all I would say, but very happy to take questions, particularly on the email I sent earlier in the week or anything else. And then also I think I'm updating on people committee as well, Jim.
Yeah, you are indeed. So before I just ask David to make his comments in relation to the audit committee, there were some additional questions which I don't think you can answer both of them, Alice. Okay. One of them is around assurances about staffing issues in finance at KGH and succession planning and continuity. Now, we did discuss that on Monday at the joint committee, so you could probably have a go at answering that. The other one was succession planning continuity in IT. So I think we might have to lodge that one for the moment because we don't have anybody apart from Richard Mitchell that could probably answer the question. So if you wouldn't mind answering that first. And by the way, Jonathan, Alice is a very sorry, Alice is a very experienced audit chair, so we're very grateful to have her with an accountancy background.
Yes, apologies, Jonathan, I didn't introduce myself. Alice, previously a KGH NED, now a UHN NED. Yeah, sorry, in terms of succession planning, I think before we had the challenges we had this year with the audit process, it was already on the cards. We had some known gaps in the finance team, to be really clear. We didn't realise how significant an impact, as I said in the email, they would have, but we did have some known gaps, which we need to address in the finance team. And it was already also on Richard's list to do a bringing together of the two finance teams and work out what skills we have, what gaps we need to fill, what we need to do jointly, and so on. We would use the word restructure, but that gives perhaps the wrong impression. It's an assessment of what he needs and where that needs to be, which is the important way to think about it, I think. That has been brought up the urgency scale for me as a result of the challenges we've had this year on the audit. I have asked Richard, as soon as we have submitted the accounts, to turn his attention, and I've said I want to agree with him the scope of that, to look at a lessons learned for what's gone wrong this year with the audit process. And part of that for me is about us having the capacity and the capability in the team, a big part of that. So it's capacity, which we've been very short of, but it's also capability, because we have had some people, but they've not necessarily had the knowledge because of the lack of previous succession planning and passing on of that knowledge and knowledge sharing. So I can't give you much assurance as at today, because sadly that has failed, and that's why we're in the position we're in to some degree. But I can give you assurance that it's very much on my agenda for working with Richard on over the next couple of months, so that in time, I'm very conscious the next year's audit cycle is not very far away from starting. It will come round quickly in the spring.
And we did get some assurance that hopefully the financial restructuring would be completed by Christmas, didn't we, Alice?
Yes.
So we have
right.
pushed. We have pushed for
yeah.
a time scale.
Yes.
So thank you,
Yeah.
Peter.
Yeah, Peter Blades. I'm Public Governor for East Northamptonshire. Alice, regarding the situation with the audit, do you think that there's a risk that we may lose Grant Thornton as auditors? Because I know throughout the NHS, a lot of trusts have significant problems in actually sourcing auditors to do the work, because there's very few companies that are large enough to tackle the problem, to tackle audits of this nature.
Yeah, absolutely. You're absolutely right, Peter, that there is a real struggle to get companies to quote for both internal and external audit work. It's not even necessarily large enough, although your point is well made, because a lot of the big firms don't want to go near NHS work because of the risk being too high and the reward not being sufficient, quite frankly. So we are left with often almost that sort of next tier down of size of firms like Grant Thornton. We are due to do an external procurement exercise, external audit procurement exercise this year in any case. So we have extended for a year with Grant Thornton on the current contract, but we're due to re-procure. I hope that they would want to bid for the work again, because it's always good to have a choice rather than one or no bids, obviously. I don't think this would necessarily put them off, but what it probably will do, and it will probably cost us this year in extra overrun fees to some degree, I'm afraid, in terms of the work they've had to do to help us catch up. It will probably mean that they would bid taking into account the cost that they know it has taken them this year. So that would be the impact I would be expecting to see, sadly.
Okay, thank you.
Thank you. And a quick word, if I may, David, because we're running hot on the quality of the discussion in the audit committee.
Yeah, general observation is I've been attending the audit meeting now for I think about a year. And I have noticed over the last 6 months or so a distinct change in the quality and the candor of discussion, which is good. And certainly at the last meeting, there was significant challenge to the execs on performance and the approaches to getting resolution to a number of issues. So generally speaking, I'm quite comfortable that the moves being put in place are actually taking effect. And I'm hopeful that we will continue to see those benefits come through. And I will say that Alice and Jill seem to be a pretty good double act in this, so they work well together. And I'll leave it there.
Thank you, David. Simon?
Just very briefly adding to what David has just said, I was at the extraordinary private meeting of the KGH board last week in dealing with our accounts, our audit from last time, which is running late. And Andrew Moore was chairing it. And at the end of it, he summed it up very briefly, very nicely, in a very friendly way. But I had a very, very strong, almost visceral feeling that if we didn't get it right, there would be consequences. Quite good to see him in action in that way. I don't know how he did it, but he did. Very, very strong. And I think that reinforces what David's just said about the sort of sea change we've seen in the last 6 months. Thank you.
Thank you for the feedback, Simon. So, Alice, sorry to ask for a very quick update on the People Committee.
That's okay. In Denise's absence, she's asked me to update. We both admitted that the last meeting had felt like quite a long time ago, because whilst we meet monthly, typically at People Committee, we haven't met over the August month. So you have the updates in your packs. I hope they're self-explanatory. Happy to take any questions. The one thing to pull out, I guess, would be on a bit of a theme, unfortunately. I guess the challenge we've been discussing, particularly in the July meeting, is that whilst an awful lot of action, there's two key priorities, I guess, People Committee at the moment. There's the people and culture and getting that right, but then there's also making the workforce financially sustainable and keeping them financially sustainable. And on the first one, I think it's a question, Richard used the words yesterday, of needing to hold our nerve on some actions that have been put in place. And I think that's true in terms of how we're dealing with that at Audit Committee. But on the second one, so the financial sustainability, a lot of actions have been put in place. We're not really yet seeing them yield the benefit. I haven't yet seen this month's numbers, admittedly, but at the July meeting, we were not yet seeing them yield as much benefit as we would hope in terms of the cost of our workforce, and also the move to people being on substantive, resulting in a change in the cost base that was noticeable and visible. So Richard may correct me if he's seen something in the latest numbers, but that was an area we were really a little bit cautious on in July, to say we really need to understand why the things we are doing, which all sound good and sensible, are not yet resulting in that benefit as much as we would hope.
Thank you. And so Simon and Jane, any comments on the quality of the discussions or anything else? Good. Okay. I think Jane's got some IT problems today, so oh, she's here.
No, the meetings are run really well, I have to say, and Denise and Deborah have both been absolutely brilliant in putting in the appropriate challenge and seeking really good reassurance and assurance that the things in place are going to do what we need them to do. So that they've been really, really brilliant, and with Alice stepping in as well on occasion to ensure that the right questions are asked, and again supporting the organisation and the culture going forward. So very good meetings. Thank you.
Thank you, colleagues. Then I think we'll move swiftly on to Sarah, because this is a very important item, and the governors did actually request, Sarah, that you come to speak to them. Sarah is our UHN Chief Operating Officer, again with lots of experience in that area. Sarah, just before we start, just for you to bear in mind, there's a few previous questions from governors which are asking about the role of the system in the urgent and emergency care work. Any previous learning from winter plans or previous winters? Have we taken advantage of that and used it in our action plans for this year? And finally, the GP strike or working to rule, how much are we taking account of that, and what sort of impact do you think it will make? So over to you. Thank you very much.
Thank you. Thank you for the introduction as well. I know the pack has been shared ahead of time. I can put it on the screen if that's helpful, but I know that you undoubtedly have access to it in your pack. So unless anybody shouts, I won't do that. We've sort of covered broadly, it's going to be a really tricky winter. So the first couple of slides sort of outline the challenges that we face, demand going up, patients needing to stay in our beds longer, impacting on the capacity we have available to meet that demand. The national priorities are consistent with what we've seen over the last number of years. 12 hours in ED, 4-hour waits to be seen, and ambulance handover times being the national standards. But of course, we look at length of stay and the other metrics, which are the enablers to delivering those national standards. So on slide 3, you can see we've provided the bed models for each site. Unsurprisingly, it does show a bed deficit position. So for Kettering, that bed deficit is 54 beds broadly. Of course, it's rolled across a 12-month period. So what this looks at is the patients we expect, because it is a forecast, will need to be admitted by month, and the capacity we would have available to service that demand. It shows a shortfall, a significant shortfall of about 3 wards worth of patients. So the NGH bed model is there as well. That shows a deficit of 71. So across the two, we have about 120 bed gap, which is significant. And I'd say it's broadly the same as what we saw last year, which, as we know, was an incredibly challenging winter. So that's sort of the currency we use to have the conversations both internally in terms of the efficiency and productivity schemes we can come up with, length of stay improvements, etc., as well as outside into the system with our partners to really scale the size of the challenge we need to collectively find ways to meet. I'll come back to that in a minute. We have historically had 2 separate UVC programmes running on each organisation. From September, we're bringing that together. So I think not only does that link back to what we were talking about, making people's lives easier, doing things once, having a UHN approach, and making sure that we are reaping the benefit of working together collaboratively. I think it also helps link into one of the questions that Jill's outlined at the beginning around how the learning has been considered in terms of the planning for this year. Because not only do we do that as business as usual per organisation, we've obviously now got an opportunity to really look at what's working well or has worked well for one site that the other site may also benefit from. So I think there's sort of 2 elements to that learning now, which present a real opportunity. And bringing that together in the new UHN UVC programme, lots of acronyms there, will really support us, I think, in making the most of those. Obviously, winter's not very far away now. So we'll sort of throw everything we've got at making sure that's maximised for this year. But I think certainly for next year, we'll be in a really strong position as far as that is concerned. So you'll see it's sort of split into 3 work streams, which sort of follow the patient journey. You've got admissions avoidance, and it's listed there on slide 4, the schemes that sit underneath there. Optimising flow through the hospital, that's sort of your length of stay, your red to green, best practice ball rounds, all of that work that I know we'll be very familiar with. And maximising discharge. That's not only our own internal process around how we're using Transfer of Care Hub, and working with partners, but also that links then into that system work with our partner colleagues around how we can improve delay and make sure that we're expediting patients through those pathways as quickly as possible. There's just some detail there, the structure on slide 5, which is about sort of a driver diagram, just to make sure that we've got our own confidence that the things we're doing are the right things that are in pursuit of what it is we're trying to deliver. Our primary goal and aim, which will be confirmed at our first meeting later this month, but the draft is improved capacity and flow throughout ED and urgent care services across UHN in line with the National Recovery Plan, reducing time in the department, time to admission, time to and improve patient experience and clinical outcomes. So broadly speaking, that's what the plan and the group is aiming to achieve. Really good progress so far. Obviously, this is work that's ongoing all the way through the year, not just in anticipation of winter. On slide 6, you can see there the improvements that have been made, particularly at Kettering, over the last year, driving down delays, getting patients through pathways 1 to 3. Those are pathways that are either supported discharges in people's homes or to rehabilitation and nursing home capacity, which is really positive because those are patients that are medically fit, waiting for their onward destination, and the more quickly we can move patients out of an acute setting to somewhere more appropriate, it's not only better for them, but creates the capacity we need to service the patients coming into the welfare floor. I've provided the NGH information there as well. It's of course a UHN pack. Needless to say, it takes about a week longer to get a patient out of Northampton than it does out of Kettering. So coming back to that learning piece and the opportunities of not only working across UHN, but particularly with the 2 local authorities, a really good example there of where we can be making improvements. We've outlined the risks to the plan. Obviously, delay in the remedial work of RAP, particularly relevant to Kettering. The primary secondary care interface work that Jill has also referenced. With regard to urgent and emergency care, so far the impact of that appears to be less than it is for elective care. We saw an initial increase in ambulance arrivals from healthcare professionals. So it's a certain category of ambulance arrivals, which are usually generated by general practice. We did see an increase across both. I'm just back from leave yesterday, so I've not reviewed the data from the last 2 weeks, which was tracking that incredibly carefully. But the impact on planned care, we are seeing much more around kind of ongoing monitoring of long-term conditions, things like that. And other internal mitigations. So this is the bit that we're doing a separate piece of work on internally, is from a physical capacity point of view, what might our additional options be in terms of escalation over that winter period. It's incredibly difficult without investment, following nicely on from Damien's update. Our challenge is replicated in the system. There isn't additional money to fund sort of schemes and the opening of extra wards, things like that, to support us. So we are working up options for consideration. Obviously, where we can do that within our current cost base, we will absolutely look to do that. Things like establishing what we currently use as boarding beds. Of course, in some cases, those beds are open, they are therefore being staffed, and they are therefore in our cost space. So looking at options like that, which would come to bridge some of that gap of 120 that I talked about at the beginning. So I think it's fair to say a lot of internal work in terms of productivity, efficiency, length of stay, etc. Review of the physical bedded capacity to see how we can absolutely maximise without spending extra money, any opportunity there. And then ongoing, very enthusiastic engagement with our system partners around how we can work together collectively in support of urgent and emergency care, which is certainly everybody's business, and arguably the most important thing that I think we're working on together at the moment as a system. I feel like I could talk about it forever, but I won't. So I will stop there and see if anyone has questions, or if anything I've said needs further explanation. I'm just aware that this might be the first time some people are hearing.
Thank you very much, Sarah. Kath.
Hi, Sarah. I'm Kath, Staff Governor. Sarah, I mean, it's clearly a very large plan, a very comprehensive plan, and as you alluded to, it goes throughout the year. But in terms of thinking about the winter, are there any aspects of that plan that it would be really worth focusing on and really driving through, perhaps, with the flow or whatever, that is worth kind of drawing out and saying this is the one or the two or the three things that is actually going to make the biggest difference for us this winter, and putting some drive into that?
Yes, definitely. I think it's a really important point. So not only do we need to be really clear about the physical bedded capacity we've got and could open at short notice if we needed to, so you've got that ability to respond. I think at our first meeting of the new UHN forum, which is later this month, that's where we'll really be able to decide what our most important priorities are over the coming weeks. Let's be honest, it's not really over the coming months. That will put us in the best possible position for this winter So as you say, we can really galvanise a lot of our collective resource and attention and effort into a few number of things, which will hopefully give us the biggest benefit moving forward. So yes, absolutely.
Thank you. Jonathan.
Hi there, Sarah. I'm the governor from Kettering Mind. My question is predominantly about referrals into the community and how well you think the organisation is connecting with external bodies. To give a specific example, but also the question can be taken more generally, we run a programme called Hospital at Home, which used to have quite a large number of referrals into it. At the moment, we've only got one referral into it, and we've seen that drop off quite dramatically in recent sort of months and years, predominantly since the sort of changes to the way NHFT has been reorganised in recent years. I'm just sort of curious to hear your thoughts on how well you think the referral programmes are working into other entities like Kettering Mind, but more broadly as well.
I think that's a really interesting point. When you first started asking your question, in my head, I was formulating my answer around, I think we maximise it where we can, but it is really clunky and inefficient in some cases in terms of what does that process actually look like. So there is inherent delay in how well we're doing it. However, by the time you finished your question, I think that clearly demonstrates that perhaps we don't. And if there are additional services, additional ways that we can be supporting patients to be living well in their own environments, then we need to be maximising that. So I would be really interested to hear more separately, but hear more about that. And it's certainly a question I think I can bring into our system coups group around how well are we challenging ourselves collectively, and are we starting to do all of the possible ways and means to support patients in their own homes to make sure that we're maximising those, not only ahead of winter, but every day. So it'd be great if we could catch up separately about it.
Thank you.
Thank you. So I think we're with David now.
Hello, Sarah. I'm David Hahn. I'm Public Governor for Corby. I don't envy your tasks, Sarah. It's huge. One of the things that kind of struck me, we mentioned this earlier, was the hospitals are already running really at max capacity. But just looking at the notes here, it says that the national recommended occupancy is now 92%. So that's been going up year on year. But all the evidence, and we did discuss this briefly at the last council meeting, that you get quite significant downturns in performance beyond around 80%. And that's quite typical in any sort of environment. So I'm just curious as to how you see that sort of impact and how you can plan to compensate for that. The other thing was given the fact that you potentially, you have all your bed capacity taken up, what effect is that going to have on the elective side of things? If you've got all these emergency admissions coming through or admissions coming through. And also, I'm just curious, and this is just point of clarification for me, really. My sort of layman's understanding of things, that when you come into winter, you basically get problems with respiratory complaints, but also end up having impacts on cardio, and then you've got orthopedics and people damaging themselves. So is my assumption there correct? And is that part of your sort of planning process in actually targeting those key areas or whatever they may be? And I'll leave it there, just curious.
Yes. So when the bed models are put together, it's based on historic demand, excuse me, with a forecast increase in demand planned across the coming year. So as you just described, over winter, people with respiratory illness, for example, the demand on those sorts of services increases, and that is played through in terms of the demand and capacity, which is what gets plugged into creating the bed model. Within that, in terms of by specialty, there are specific conversations and discussions that happen around what might the response in that specialty need to look like in order to recognise that respiratory might look quite different to urology, for example. That isn't something that we have seasonality around in the same way. So out in the community, there is schemes around acute respiratory hubs, which were initially set up during COVID, but of course, you know, in terms of respiratory disease, were seen to be beneficial. So opportunities like that are considered. At Northampton, we have a respiratory something unit, RSU, I'm not sure what the S is, which is about 12 beds. At the moment, it's not really used for us, but it should be sort of NIV and that sort of higher, more complicated end of respiratory. At the moment, those patients are just scattered across the respiratory wards, but if we were able to use that space with the proper skill, mixed staff and equipment, the idea would be we reduce the length of stay for those patients. They're being cared for in the best possible place by the most skilled staff for their illness, thereby creating efficiency. So it's those sorts of things that we look at, which is relevant to specialties. I've forgotten what the first part of the question was.
So have I.
Was it about elective care?
It was electives, yes. So that is a very real challenge that every trust faces, every winter during times of pressure. I'm really pleased though that this winter just gone, neither trust cancelled elective activity as a result of emergency care demand, which is incredibly positive. We would of course be looking to do the same thing again this year. My personal view is that when you do something like take orthopedics down to take the ward over, you get some respite for probably 48 hours while those beds are being filled. And then you've got nowhere else to go, you're still stuck, you haven't actually resolved it. And more often than not, it takes a minimum of 2 weeks, but usually 4 weeks, to come out of that sort of decision, come out of the ward in order to put kids back on. Meanwhile, you've of course got hundreds of orthopedic patients that have not been able to proceed with their surgery. We are very familiar with the negative impacts, not only for the patient's physical health and fact being delayed, but their well-being as having made that decision as well. So my personal view is we shouldn't be doing it. I don't think it solves the problem. I think that it's a momentary respite for the couple of days. But very positive that we didn't do it last year, and we certainly have no plans to do it this time.
Thank you, Sarah. We've got 2 minutes. So I'm going to, David, if you'll bear with me, just ask Jane, then Keith, then yourself to just make a final comment in the last 2 minutes, and Sarah to respond briefly, if you may. I'm so sorry that we're running late, but we've had some really fruitful discussions. So Jane first.
Sarah, thank you for your presentation. My name is Jane. I'm a staff governor at Kettering General Hospital. So there's a couple of things really that you can come back to us on, not necessarily for you to answer today, but actually as a group of governors, public and staff, how do we support the community to make the right decisions around the places of care that they should be going? You know, because we spoke about pharmacists that can potentially support people with medication and things like that. How do we support our colleagues through the challenges of what is likely to be a very bleak winter? Having been a discharge coordinator and a capacity coordinator, I know what those challenges can be like around that period. And what I haven't seen in this brilliant PowerPoint presentation is the communication plan that we've got going out to patients and colleagues about, well, what we're doing, how we're doing it, and the warnings of using our services inappropriately. Thank you.
Thanks, Jane. Keith?
We know that the problem, all these problems with A&E, all starts from the general practice. I'm on the PPG of my local surgery, which should have 7,000 odd patients on the books. They've got 14,000. So they don't see anybody. Now, this goes down to the Corby urgent care, which is basically ended up as a general practice. And then it comes then back into the hospital, which is actually snowing that up. The problem is from the top, and we really, it's a pity they didn't do a piece on the television to explain to people that an urgent care is for urgent care. It is not a general practice.
Thank you, Keith. And quickly, David?
Yeah, this is just an observation, really. I don't know if it's relevant or not. One of the things that's always struck me is there's never any focus coming up to the winter months on prevention and things that people can actually do. And it always seemed to me that the public health aspects of this seem to be sort of missing. It's just an observation.
Thank you. And Sarah has popped into her slides the introduction of the new RSV vaccination, which is something I think we all welcome. Sarah, any final observations before you have to go?
No, I don't think so, aside from following up with Jonathan in terms of mind and alternative sort of options around how we're supporting patients at home. And then picking up on Jane's points about supporting the community to make good choices, supporting colleagues during times of pressure on the Commons plan. So the Commons plan is in development, meeting with Sam later this afternoon, but we started discussing it yesterday at board development, didn't finish. So they're doing a lot of work, particularly in understanding what's worked well in the past. So they're mapping A&E attendance against when comms messages went out last winter, so that we can really understand the sorts of messages, the timing and the impact, so that we can make sure that we're sending the right sorts of messages and communication at the right times in order that we're reaping the best benefit. So that's a really interesting piece of work that I'm hoping will help us maximise how we're communicating, particularly with the community. So thank you for your question. I think it was really helpful.
Yeah, that's great. Thank you, Sarah. Pauline, is it very quick, please?
Yeah, it's very quick. I don't know what the answer is to the GP work to rule question. My connection dropped out, so it might have been addressed, but I'm not sure it was.
So I said that in urgent care, we haven't seen as big an impact as we have across fund care. Initially, we had seen an increase in ambulance arrivals generated from healthcare professionals, which are usually GPs. And that's as a result of doing their standardised number of patients per clinic and not being able to see everybody. So that's being tracked on a daily basis. I said that I've just got back from leave, so I haven't seen the data from the last 2 weeks in order to see whether that has settled, whether it's continued in the vein we were seeing, or whether indeed it's got worse. But we do tracking processes in place within the trust, and that is sort of shared and then discussed collectively with the system to make sure we're being responsive to any changes in patterns of demand that we see as a result.
Thank you very much indeed, and thank you, Pauline, for getting that clarification. So thank you, Sarah. I know you have to go. I'm sorry we've kept you, but it was obviously very useful to see your slide pack and have that discussion. So, colleagues, I'm afraid we're going to have to canter through the next half hour. We are now on to the board committee summaries. So we've already done some of them, thankfully. But I think if we go back to the beginning, Caroline, I understand that you will be feeding back in relation to the Operational Performance Committee.
I haven't actually been asked to, so I haven't actually prepared for that. I don't know whether Chris was going to do that, because Chris will be doing clinical quality and safety. I haven't been asked.
Okay.
So I've not actually prepared.
Apologies, Caroline, I had you down as being the speaker.
I mean, I can see that the limited assurance item was the winter operational plan, and I think we've largely covered that one off. I don't think there's anything else that I can add to that.
Okay. Chris, do you have anything to say on this committee feedback?
No, I haven't. Nothing additional.
Thank you. And as you say, Caroline, we've just done a big agenda item on the winter plan, so that's enormously helpful. Fairly new committee, which is the feedback has generally been that it's enormously helpful to have that space to discuss these issues. And the governor is Graham again, is that right?
Yeah, I've been doing those. I think I missed one, but you're right about the space thing, because the agendas before were far too full and constricted for proper discussion, and so now you can see from the notes that there's good discussions and a lot of detail being gone into, and as you say, discussion on the things that are coming up. So in the interest of brevity, all good.
Thank you, Graham. So I'm next for the NGH Audit Committee. I don't have anything to add other than what is written in the pack, except perhaps to say there is good news in relation to consultant job planning, because in the meeting we had on Monday, both KGH and NGH have now reached respectively 75% and 79% completion of the consultant job plans. We'll get some more assurances at our next meeting. So I'll move on then to just having a look what we've done already. I think we're now back to you, Chris, please. And if you wouldn't mind just introducing yourself.
Thank you very much, Jill. My name is Chris Welsh. I convene the Quality and Safety Committee for UHN, and I'm a UHN NED. So first of all, apologies for joining the meeting late, as opposed to leaving early. And I was going to talk about urgent, so there are notes in the pack, but I was going to say something about urgent care, but that's been covered. So I'm just going to draw a couple of things to your attention. One is the continuing issue with RARC in the concrete problem in the Rockingham wing, which has, part of it has moved into new accommodation successfully towards the end of last month, and that's a really good step forward. The only other thing I was going to mention was both sites have checked out their mortuaries and the security standards in relation to mortuaries as a consequence of that awful case in Kent some years ago, in which there was abuse of the dead. And at KGH, there are some shortfalls which are being corrected, particularly with regards to video recording and completing the entrance and exit using swipe cards to record who has accessed the mortuary and how long they have been there. That was all I was going to say, but the rest of the notes are in the pack, and I'm happy to answer any questions.
Thank you, Chris. And before I move on to David as the relevant governor, the other thing that we've been discussing more recently is the pathways and waiting lists for neurodiverse children. So Caroline, can I just give you the opportunity to introduce yourself, because you've been a very valuable member in the committee for that discussion.
Thank you. Yes, my name's Caroline Stevens. I was previously NGH NED and just becoming a UHN NED and also the Senior Independent Director as well. I'm in my other role that I have, I'm the Chief Executive at the National Autistic Society. So yes, there was a key discussion around our concerns around assessments and diagnoses for autistic children of primary school age, where unfortunately the provider has gone out of business and we don't have an alternative. So it is something that our medical director is looking into, like many trusts across the whole of the country. There is a massive waiting time for autism diagnoses, and so it is something that we need to look at quite urgently. But the medical director does have a plan to look at that.
Thank you very much. And then the next item, actually, we don't have anybody to speak to because it was the partnership committee. Richard, I don't know, Mitchell, if you wanted to say anything about this or whether we just take it as read.
Richard Mitchell's had to go to another meeting. Sorry, Jill.
Thank you.
But as
Apologies,
another
I hadn't
Richard in
seen
the
that.
room, I'm happy to
Oh,
take
right.
any
Okay.
questions.
Fabulous.
So, Jonathan, hi, good to meet you. I'm Richard Apps. Sorry, at least 3 Richards on this call, and we've referred to the 4th Richard, who's Richard Wheeler, who's the Director of Finance. I'm Richard Apps. I'm the Director of Corporate and Legal Affairs. So the Partnership Board, for those that aren't aware, is a new joint committee between Kettering, Northampton and University Hospitals of Leicester's boards, and its purpose is to steer that a very high level collaboration between the organisations that Richard Mitchell touched on a little bit earlier on. We've only had 2 meetings. I'm happy to take any questions based on what's in the pack, but at this stage it's still very high level and early days, I think, in terms of the decisions that that meeting is taking.
Thank you, very helpful, and apologies, David, I didn't come back to you in relation to the quality of the discussion at the Quality Committee.
Okay, in terms of the Quality Committee, I'll be very brief. My views are very much the same as that of the Audit Committee. My impressions are that things are actually working far better than they used to do, and that there is very much more open discussion, and I think more of a candid approach and sort of deep diving and challenge. So I'm very comfortable with that. And I would also like to say that thank you to both Chris and Jill publicly. They've been very good with their time when I've actually approached them to give feedback and so forth. And I'm very pleased because it's a bit of a reboot, I think, between the relationship between NEDs and governors. And I'm hoping that that will continue because I think it's quite valuable. I'll leave that there. There was one item for Richard Apps, actually, if I can just quickly, Jill.
Sure.
Given all the changes, Richard, would it be possible for the governors to get some kind of roadmap, an org chart with all these committees and so forth, and who's doing what and what they're, because every time I look at these packs of papers, there seems to be another one popping up, or there's been a change, and I've kind of lost track of where everything is. I think it would be quite useful if that's possible.
Yeah, thank you, David. So you are not the first person to ask that question. There have been a lot of changes over the last few months, and we've still got, as far as committees are concerned, we've just undertaken a review of where we are after a few months. But yes, absolutely, we have a draft governance handbook or manual or whatever you want to call it. In reality, it's a PowerPoint with several pages in that describes this is how we organise ourselves. So very happy to finalise that off now that the council has approved those final non-executive appointments. That's something that we can do in the coming week.
Lovely, thank you, and all credit to you, David. Please keep the feedback coming in. It's immensely helpful. So thank you. So moving quickly on then, please. So we have the reports from governors on engagement activities. I don't know how you want to manage this. So I've got presenter Richard May, author Richard May. Do we take it as read in the absence of a lot of time, or how do you want to manage the discussion, please?
Thanks, Jill. I'm not really author, probably more editor in terms of pulling together the material that governors have given me and my team. I would suggest we open it out to governors to talk about some of the things they've been doing if they'd like to, drawing particular attention to an engagement event that we held last week in Wellingborough. Thank you.
Thank you. Bearing in mind we probably only have a few minutes, but if that's okay. Was it you, Jane, going to say something?
I was going to say, would you like me to pick up the engagement event, Richard?
Can I just drop in and say yes, please, Jane?
It was,
and then I'll have just a very few words on the other bits plus another event. So
super. Okay, fire away.
We've had two engagement events in all honesty. We had the community engagement event where several governors, Lindsay Alvis, one of our governors who's not here today, he's on holiday, put together and arranged and orchestrated with the support of Graham Lawman a health awareness event that was held at the Swansgate Centre. It promoted several services from across all of our trusts and wider. So there were third sector services as well that support hospitals and patients. And we recruited additional members to the membership of KGH, which was one of the prime reasons for doing it, as well as engaging with other services to find out what they do, how they support the hospital, and dovetailing into how that could support the Reimagining Planned Care programme, which is my substantive role. And yesterday, I don't want to steal Mike's thunder, but I'll steal it a little bit. Mike has been doing a fantastic job in creating events to support our staff governor personas within the organisation. And I think we've got a little bit of work to do to engage wider with staff so that they know what our role is and how we can support them better. But we have already secured the Swansgate Centre for next year, and we have an ambition to do 4 of those events a year, 1 in Northampton, 1 in Kettering, 1 in Corby, and return to Wellingborough, so that we start collating all of that information and supporting and gathering feedback and highlighting with the county. Thank you.
Thank you. Who was next? Was it you, Simon?
Yeah, just briefly on item 7, reports from governors. We've had 7. There are 7 written reports in the papers, which I think I'll leave people to read unless anybody who reported is here that wants to add, or anybody wants to ask questions. That they were 4 from public governors and 3 from staff governors, and thank you for those. We are looking to improve that process, so we're starting now to get some reporting sheets so that people, when people do a walk around in the hospital, for example, they can report, and I would hope we would collate those for this section in the future. Apologies that I should have put a paper in and haven't, but I will add it, send it to Richard to add to the minutes. We also, so it will be about a governor community engagement workshop, which we held back in June, which was to get as many governors as we could together to just have a general chat about engaging, and we did that in the rec hall, and we had the start of some good discussions. And I think what's come out of that for me, and what's come out of other activities, is that the governors would like to organise a conference, is probably the wrong word, a meeting at anywhere, a workshop with the NEDs, so that we can all get to know each other better, all get to understand where we're coming from, and start a, it would I think it would help. That's really quite a new idea, and it hasn't been developed. I think that's probably all I need to say, and then I can hand on to Jane really for item 8, which I think she may already have covered really with the description of Lindsay's event.
And just to say on behalf of the NEDs, I'm sure we would welcome that, particularly those of us that know the governors less well than others. So that would be good. Jane, anything to add in relation to item 8, please?
No, I'm not sure if my network has dropped out.
Yes, it does keep coming and going, I'm sorry to say. Okay, thank you. Simon, you had Meet the Governors Forum. Anything additional to say?
I can talk briefly to that. The last forum we had yourself actually, and Fahana from the EDI team for with some pre-prepared questions for both you. really productive, because what we're now doing for the forum is to get 2 individual people, usually a NED and a working officer from the hospitals, to talk about specific subjects, and it is very productive and very interesting. That's good. Not much to say beyond that. The other thing I was going to say, I think, was that I think just really to say that equality and diversity, I think we've already underlined that. It really is on the agenda. It needs to, I think our conclusion is it needs to run like a stick of rock. It isn't just for Hannah doing all that work and all that training. It's about actually living it. And I think there have been questions today on that, which have been responded to. And just to say, the other thing that came out of that was the need to have this conference, whatever we call it, with the NEDs. I don't think I need to add anything to that unless Jane wants to.
Thank you, Simon. We do have a question from Mike.
Yeah.
Yeah, it's not a question. Sorry, it's Mike Corcoran. I'm a staff governor. Hello, everybody. It's just to mention the staff consultation that I organised yesterday with Jane in the entrance to KGH. I just wanted to say you cannot beat face-to-face contact with our staff. I know the staff survey is really important, but I really do feel there needs to be more investment in actually talking to people and getting to know them and raising the profile both of the governors but also of the NEDs as well, because part of the consultation was about raising the profile of staff governors. Lots of staff knew about staff governors but didn't know what we did. And when I mentioned non-executive members, it was just blank. What the heck does that mean? So there's a piece of work to be done there in terms of demystifying who is on the board and who makes decisions, because one of the issues that came up was about management and it being quite distant and decisions made and people not feeling that they're fully engaged. So I'll be sharing the feedback that we got from probably over 30 to 35 staff members over a period of about 3 hours, and it was really, really helpful. Thanks.
Thank you, Mike. Points very well made. So Richard Apps advised me yesterday that we're going to go back to having boards on the relevant sites, i.e. KGH and NGH, because we had moved away from doing that because there were so many of us. Now we're smaller in number. That's another advantage. We're going to hold the boards on the site and we're going to do walkabouts, I believe, Richard. So we will be more visible. And also we've got a meeting of NEDs next week where we're going to talk about visits to make sure that that's something that I think has probably dropped off a bit, that we pick up and make sure that we do make ourselves known to staff and patients on a regular basis. So their points very well made. So thank you. So I think the next paper, Rashmi isn't here and is for information only. And so we're then on to any other business. And Richard, you wanted to bring up the annual members meeting. Richard May, sorry. Oh, sorry, David.
Let Richard go first. I've got something else I'd just like to touch on before we end the meeting.
Yeah, great. Okay. Richard, fire away.
Thank you. It was a date for Governor's Diaries, the annual members meeting for Kettering, jointly with Northampton, which has to hold an annual general meeting, slightly different but same overall purpose, in the diary for Thursday the 19th of September. And this year we're holding it at Kettering, and we've invited a number of stall holders to the education centre at Kettering to make it more of a service showcase from various teams and departments. The slight complication this year arises from the issues that are being brought to your attention about the completion of the annual report and the accounts. I suppose the simple message is, come what may, we will be running an engagement event on the 19th. It may, or it's not 100% guaranteed to be the Kettering annual members meeting yet, but there will be an engagement event that day at Kettering. So watch this space for more comms about that event. But I would encourage you all to attend and to spread the word if you can. Thank you.
Any
Thanks,
idea what
Richard.
time? Any idea what time?
Yep, it is. The exhibitions are at 4 o'clock, and then the formal meeting is at 5 o'clock, and it will be finished at 6 o'clock. Thank you.
Another opportunity for us to be visible, Richard. That's good. David.
Yeah, I just wanted to raise a couple of points, and these are very much my personal views. The governors were asked to give approval to the energy centre spend, and we had a meeting for that. That meeting lasted about 45 minutes. I felt very uncomfortable with that. The business case was 108 pages of fairly detailed material. There were a couple of supplementary documents which appeared to be sort of rather repetitious of the main business case. As I was reading through that, I couldn't find the appendices which were referenced, so when I wanted to go and reference things, I couldn't. That project had been going on for a very long time, and yes, the governors were given a couple of hours and were given a walk around the site and so forth some weeks earlier, and then we were 45 minutes. But given the scale, the expenditure and the complexity of that material, I think asking the governors to sit down there and really give a valued judgment, yeah, go ahead with that, we're comfortable, is a bit of a big ask. I did read all 108 pages, and when I questioned some of the numbers in the report, because they just didn't add up as far as I could see, and I did have somebody else check them for me, there was no explanation. When I asked about how this fitted into the long-term strategy with the new office build, the new hospital build, there wasn't really a comprehensive take on that. And I know for a fact that there are quite significant changes coming down the track over the next 10, 15 years in terms of the way power is managed. So I think there are some issues there. And what I would ask is that the board, the NEDs and the execs consider how they can actually take the governors along the process so that when we come to these decision points, we are much more informed about the material. Because at the moment, and again, this is just my personal perception, at the moment, it feels more like the governors being part of a tick box exercise. That may not be the intent, but personally, I was uncomfortable with it. And given that we're coming up, potentially going through a multi-year project with a new hospital build, I would ask that they consider how there is some kind of arrangement put in place for a group to actually work through with the hospital teams all the way through so that we're not suddenly plonked at the end of these things and we have something dumped on us.
So David, before I ask Richard Apson and Simon how they'd like to take that forward, did you have another point?
No.
Oh, that's it. Okay,
that's
fabulous. It. Yeah. So Richard and Simon, what would you like to do in response to David's question?
Well, shall I go first? And because I guess I kind of I support David's point, actually. I've also heard non-execs raise the same issue about the size of reports and so on. They are horrendously complex, extremely difficult to understand, and some of the normal KPIs of the hospitals fall into that category. And sometimes you feel that some of it is almost designed to obfuscate. It is very difficult. And a simple explanation so that we can really understand what we're making a decision about or giving approval to would be really, really helpful. It's always going to be difficult to understand the detail of something like that unless you're a specialist in construction and power supply, for example, in the case of the energy centre. But actually, you need to be that just to understand the report, never mind make a decision. That makes sense.
Thank you, Simon, for the feedback, and David.
Yeah.
Richard Apps, have you got a suggestion how we take this forward?
So I think there's a few things in there to unpick. So in terms of general report writing overall, we continue to support colleagues across the organisation with training. We did a whole day on effective committee working earlier this year with the support of NHS providers, an external organisation that supports foundation trusts and NHS trusts, and we continue to do that. Andrew Moore, our chair at the last public board meeting, made some very clear statements about the quality of reports and the timeliness of reports being submitted and distributed, and those messages are being reiterated to executive colleagues. In terms of things like the new hospital programme, the energy centre, and the governor's role in approving what's called a significant transaction, for which there is no national definition, but we interpret locally. There's a couple of points in there, I suppose. One is just to reiterate that the Council of Governors' role is to approve something that's a significant transaction when it's deemed to be a significant transaction. But the governor's role predominantly is to judge whether the trust board has gone through a sufficient and sensible process in reaching its determination. And there is an SOP and a policy, if you like, attached to the KGH constitution that supports how that works. I do think it is very, very complicated and difficult and challenging to understand national full business case templates. They are a mandatory thing that we must do in order to get the Department of Health and the Treasury and others to approve drawdowns of multi-million pounds worth of money. So it is very, very challenging. I completely take the point that we need to support governors and non-executives and all board members to understand that process and do it in a staged way. I think there is a lot of uncertainty about the national programme, political uncertainty about the National New Hospitals Programme, and certainly in the time that I've been with Kettering General Hospital, it feels like we've been around that loop several times of there will be funding, we're not sure, there will be funding, when is the funding coming? So I think there is something about explaining where we are in the process, and the board spent some time talking about that process yesterday. And I think it would be really helpful if we invite Polly Grimmett and her team to come and see the Council of Governors again to talk through where we are, where we think we are, and what we're going to do next. I do take the point completely, David, that these are complex and the governors need to be taken on the journey all the way through. I think the complexity is that the journey keeps changing from a national perspective.
Thank you, and apologies that we're over time, but I think, again, these are points well made. So, David?
Yeah, I'll just come back in that very, very briefly. I accept the points you're making, Richard, about the templates and so forth. I've got some familiarity with the procurement processes and so forth. But from a personal perspective, and I understand about the approval process and it ensuring that the process has gone through. But from my perspective, and I'm maybe wrong here, but it's also about ensuring that that process is being robust. And that's the point I'm getting to. We need to have the information taken along the journey so that we can do that. And I think we're much, much more likely to get to those points and in future have reduced the risk of conflict between the governors and anybody else if we can actually be part of that journey, if that makes sense.
Absolutely right, David. So we'll leave Richard to have a conversation with Polly and her team. And this is an action for this meeting that Polly is invited to speak to the Council of Governors on this topic. Richard, you have the final word. Oh, not quite.
No, thought I've some extra clarification. I hope is helpful and context on this issue. The procedure that Richard mentioned is actually very new for significant transactions. It was adopted during the energy centre process, so for that reason it was more difficult to be able to see it right through from start to finish. We will do, if you look at the procedure which is available on the website and you approved, it does enshrine governor involvement throughout the process. couple of points specifically on the energy centre. I believe the national programme team did give us quite short notice to get the full business case for this through much quicker than we were anticipating, which is partly why it was slightly shorter than we'd have liked. But we did hold an open day for governors. We invited, I think, about 10 or 12 governors came into KGH. We did a site visit in the middle of May, and Polly's team gave a comprehensive presentation on the energy centre. So we did do what we can, but points noted for the future. Thank you.
Thank you. And Peter, you have the final word.
Thank you. Yeah, it was just to ask everybody if they can publicise the skincare days that dermatology have got planned for this Saturday in Kettering and Monday in Corby. Details were in the newsletter that came round. It may well help to reduce some of the load on GPs, etc. Okay,
Great, thank you for flagging that, Peter. Okay, I think we are now finished. So apologies for running over, but I think we've had very high levels of participation, which is what this meeting's all about. So thank you very much, everybody, and see some or all of you soon.
Thank you.
Bye.